With that, I'd like to introduce Yousuf Zafar, kind of building on the theme of kind of moving outside of just talking about physical side effects. Dr. Zafar has started to teach us about how we need to think about the financial toxicity of some of the agents we give, and has done a lot of work in this area, and I think very timely given some of the discussions earlier tonight around these oral agents that we're using. So thank you so much for coming.
Thank you for having me. You guys hear me okay? Great. So I am a GI oncologist. I don't know how you let a gastrointestinal oncologist into this fine group of people. But I was in clinic today, and the topic that I'm going to talk about today actually had immediate implications on some patients that I talked to in clinic. And I'd like to actually tell you about one of my patients. And patient name was Chris. He was diagnosed with colorectal cancer at a very young age, so in his 30s. So I started Chris on a very standard treatment with oral chemotherapy and radiation, and he did really well with it. He tolerated the chemotherapy fine, no side effects. But unfortunately, after he finished his treatment, repeated scans and found that his cancer had spread to his liver. So I started talking to him again about his next course of treatment. And I said, look, you did really well with the chemotherapy. You'll tolerate it fine, and I'll help you get through it. I started my usual spiel about the side effects of chemotherapy and the procedures. And I said, you know, it's going to include that oral chemotherapy you were on before, plus a couple other drugs. Halfway through my spiel, he interrupts me and he says, you know what, doc, I can't do that. I can't do that treatment. And I was a little bit taken aback because, like I said, he had tolerated his treatment so well. But it turns out Chris was not concerned about the physical toxicity of treatment, but he was concerned about the financial toxicity. Chris had a job. Chris had insurance. Chris did not have prescription drug coverage. So that oral chemotherapy that I prescribed him, he paid for all of it out of pocket, and over the course of a few weeks, literally, accumulated thousands of dollars in medical debt, which for someone who worked as a trucking dispatcher was a tremendous, if not life-altering amount of money. And as I'm sure many of you know, Chris is not alone. And a large proportion, if not the majority of patients who we treat experience financial toxicity to some degree. So I'm going to talk a little bit about why it happens, and importantly talk about what we can do about it. So why does it happen? Well, a lot of it has to do with the price of the drugs that we're using, and a lot of these are great drugs, but that innovation is coming at a price. So let me show you something. So these are prices per month of chemotherapy over the past few decades. All right, so this is, each one of these dots is a price of a month of chemotherapy. So from the 1970s to the 1990s, on average, chemotherapy cost a few hundred to maybe a couple $1,000 per month. So after the 1990s, we see this surge in the price of drugs, where today, the drugs that we use cost 10 or tens of thousands of dollars per month. So why is that happening? Well, a lot of it has to do with the type of drugs that are entering the market, right? When I first started in this job, everybody was talking about these biologic agents, these targeted agents. Well, today, we're all talking about immune therapy. And immune therapy, we thought biologic agents were expensive. Immune therapy put the targeted antibodies to shame when it comes to the price, right? But what does that mean to patients, right? Most of us have insurance, and those drugs are, for the most part, covered by insurance. Well, despite having insurance, on average, patients are paying thousands of dollars out of pocket for both oral and IV chemotherapy, not to mention MRIs and PET scans and other procedures that all of our patients go through. So those costs really add up. And they add up to the point of causing extreme financial distress. And in fact, there was a really interesting study that showed that just having a cancer diagnosis more than doubled the risk of declaring personal bankruptcy. So you didn't have to beyond Opdivo, right? But just having a cancer diagnosis was enough to put patients at risk for extreme, if not the most extreme, financial distress. But here's where the data gets really interesting. So it's not just that cancer can make you go bankrupt, but what else? What else can that financial toxicity do? So the same investigators who did this study took it a step further and said, well, what happened to patients who declare bankruptcy? And what they found was that cancer patients who declare bankruptcy are at a 79% greater risk of dying compared to those who don't declare bankruptcy. That to me is incredibly unfortunate. And this is what I've spent the past 7 or 8 years working on, is this concept of financial toxicity. And the question that I've been asking is why? So why is there this relationship between extreme financial distress and patients doing worse as a result? Well, I think there's a few different answers. The first is its impact on well-being. The first study I did a few years ago asked the questions of what are patients doing to cope with out-of-pocket costs related to their cancer care, despite having insurance. The majority of patients were giving up vacations. About half were spending less on food and clothing. And about half were spending their savings. And in most of these cases, these folks on my study, they're spending their retirement savings. So we also asked patients in a different study what they were willing to do to pay for their cancer care. About half were willing to declare bankruptcy. 39% were willing to sell their homes. Interestingly, when we wrote the study, we didn't ask patients what were they willing to do for a cure, or what were you willing to do for the best cancer treatment. You know, if you were to be treated by Dr. Salama, for example, right? Not Dr. Hanks. But what would you be willing to do for not even the best cancer treatment, for any treatment? And patients, without understanding completely what is the impact of treatment, we're still willing to make tremendous financial sacrifices and sacrifices for their well-being. And I think that really puts and should put a lot of burden on me as the oncologist to make sure that every time I prescribe a treatment for a patient, that patient knows exactly what they're getting out of it. So what else is a factor that might explain this relationship? Well, I think health-related quality of life is one, and that's distinct from well-being. It's a distinct entity. And what we found when we measure quality of life among patients who are receiving cancer treatment, we find that as financial burden goes up, quality of life goes down. And we know as quality of life decreases, that has a direct impact on how well patients do. But I think the factor that is most important in explaining this relationship between high financial distress and worse outcomes is quality of care. And by that, I mean adherence and being able to afford the care that your doctor prescribes. So let me walk you through a couple examples. There was an interesting study that was done just down the street at UNC, where they looked at patients who've been diagnosed with chronic leukemia, been prescribed a drug that we know is potentially life-saving in that disease. It's called Gleevec. Might have heard of it. And what they found was that patients who had a higher copay, monthly copay for Gleevec, were 70% more likely to stop taking that drug. So what was a high monthly copay in this study? It wasn't thousands of dollars a month. It wasn't hundreds of dollars a month. It was $53 a month. 53. So patients who had higher than monthly copay of higher than $53 a month, statistically were at a 70% greater risk of stopping this potentially life-saving drug. That's the scale of the problem that we're dealing with today. We did a study where we found that nearly half the patients on this study reported not taking their treatment in some way because of cost. So there are many reasons that at least I've gone through that might explain this relationship. There may be others that you've thought of that I haven't thought of yet. But what we have today, over the past 7 or 8 years, is multiple studies that have shown an evidence-based for the financial toxicity of cancer treatment. All these things up here, there's been a study that has shown all these effects. And so what I say today is it's time to intervene. It's time to intervene and help patients afford their care better. So how do we do that? That's the hard part, right? Well, I think we have to intervene at 3 levels. We have to intervene at the policy level, we have to intervene at the provider level, and then we have to intervene at the patient level. So my primary, lately I've been working a lot more on the policy side, but I want to spend most of the time talking about provider-patient interventions, but we got to talk policy, right? Every once in a while, you guys might hear a little bit about health policy in the news. I was on Capitol Hill last week talking to our senators and representatives about what they're doing to help our cancer patients afford care better. And I can tell you the conversations were not the most productive conversations I've ever had. But let's say we were to make policy interventions to help make care more affordable. Well, we'd have to intervene at all these levels, right? So manufacturers need to make drugs more affordable. And the CEOs of these companies are saying the same thing, so they agree with me, but I'm not seeing any movement on that yet. The government needs to intervene. We need to be allowed to negotiate for the price of drugs in the same way that happens in Australia and Europe and the UK and Canada, but not here. Insurers need to do a lot more, right? They're the ones that are passing the cost of the drugs on to you as patients, right? So what if we thought about value-based insurance, where we know high-value interventions like Opdivo for melanoma? That's a drug you guys use, right? Okay, I just want to make sure. I don't treat melanoma. But Opdivo for melanoma, which we know is a high-value intervention, that should not have any copay for patients. Because what other choice would a patient have than to take the drug that their oncologist has prescribed? And health systems have a role as well. And health systems need to be more transparent about what the prices are that patients are going to face. But what about at the level of the patient and provider? Well, if we think about any symptom, we intervene on any symptom that cancers or our treatments cause by preventing it, like fatigue, assessing for it and checking in with our patients, and doing what we can to reduce that symptom. So take out fatigue and replace it with financial toxicity. And that's what we should be doing as well. We should be doing whatever we can to prevent financial toxicity by focusing on high-value treatments. We need to assess it, so we as providers need to be checking in with you regularly and saying, can you afford this treatment? And if not, refer you to our entire staff of financial counselors or social workers. And then we need to figure out what we can do to reduce financial toxicity. And that's what I've been working on mostly over the past few years. There's a lot we can do here. So we did a study where I asked patients, do you want to talk to your care team about your costs? And about half of the patients said they wanted to have that conversation, but only 19% had actually had a cost discussion. So there's this great divide, right? So then we asked patients, well, why don't you want to have a cost discussion? And they said they were embarrassed. Or they said they didn't think it was their doctor's job. Or they said, well, I don't think there was anything we could do about it anyway. So that's really interesting, because when we looked at that small sample of patients who did talk about costs, 57% said their out-of-pocket costs were lower after talking to their oncologist. So why did that happen? Well, it happened because their healthcare team referred the patients to financial assistance, talked to the insurance company, and 78% of the time, costs were lowered without changing treatment. And that's really important. There is a typo here. It says MD appealed to insurance. Let's all be frank. It wasn't the doctor, right? We all know that. We all know who it was, right? It was great nurses and advanced practice providers that we all work with. But the point is we have a team, right? And if you don't think it's your doctor's job, well, it absolutely is, because it's our job to make sure our patients get the treatment we prescribe. I might not know what the price is of any particular treatment, but I sure do know who to send you to for help. So what else are we doing? I have been working on an app for patients where you can learn how to talk to your healthcare team about costs, where you can go to learn about financial resources, and to learn about assistance programs to help decrease your costs. And I'm just going to show you a brief 45-second video to show you how this works.
Welcome to Pathlight, an online tool that helps patients with cancer and their loved ones ease the financial stress associated with cancer treatment. Using videos, online tools, and informational materials, Pathlight empowers you to better understand and reduce the expenses related to your treatment. A diagnosis of cancer can be challenging. Even though you might not be feeling your best, you still have to make it to your doctor's appointment, undergo tests, and receive treatment. All of this while balancing responsibilities at home and work. The last thing you need to worry about is money. Unfortunately, one of the unspoken challenges cancer patients face is cost. To face mounting bills from their treatment. In fact, research has shown that 1 out of 3 families have trouble making ends meet due to healthcare bills. The average insured cancer patient might be paying hundreds of dollars a month out of pocket for their treatment. If you are experiencing unexpected out-of-pocket costs from your treatment, it's normal to feel worried about costs, and Pathlight can help reduce that worry. First, Pathlight can guide you through important topics related to insurance and affording healthcare. Second, Pathlight can connect you to financial assistance resources specific to your treatment and financial situation. And third, Pathlight can coach you through the process of talking to your healthcare team about costs if that conversation is important to you. Pathlight aims to reduce your worry about treatment costs, so you can instead focus on what's most important to you.
So why did Chris experience the financial distress, the financial toxicity he did? Well, for 2 reasons. First, he didn't think he had any options, and he didn't mention his financial distress to me as his oncologist. But most importantly, I didn't ask him. So since then, I spent a lot more time asking my patients about whether or not they can afford their care, and I've been surprised at the answers I've gotten. But there's a lot more work we can do in this area, and what I want you to know is that you're not alone, just like the video says, and there are a lot of resources out there to help you if you need it. Thanks.